Good evening, everybody, and welcome to the Daily Mavericks 50th live journalism webinar. At the outset, let me say thank you to all of you who have supported these webinars, either as sponsors or just as interested parties, people. There's clearly a lot of interest in tonight's webinar because we have, I think at the last count, 2,066 people who had registered for the webinar. And I think I can understand that because we haven't had a discussion about where we are with the COVID-19 epidemic for a couple of months. And a lot has happened. But we're very fortunate tonight to be joined again by Professor Shabir Madhi, who you can see sitting not with me, but somewhere in space. You've met Shabir before. We talked to him for the first time on the 10th of May, for the second time on the 28th of June. And I'm not going to go through Shabir's extensive CV, except to remind you that Shabir is the principal investigator on the main vaccine trial, COVID-19 vaccine trial that's taking place in South Africa. He's the Dean of the Faculty of Health Sciences at Wits University. He will take up that position on the 1st of January next year. He's a world-respected vaccinologist, and he is a member of the Ministerial Advisory Committee on COVID-19. There was a lot of interest in tonight's webinar. A number of readers have submitted questions, very helpful questions. So before I bring Shabir in, I'd just like to tell you about how I intend to structure our discussion over the next hour. There's really three areas, Professor Madhi, that I want you to help us to explore. The first area will just be to look back on the last 4 months of the COVID-19 epidemic in South Africa and try to make sense about what our country has gone through. There are many listeners, readers with questions on that. The second area will be to take advantage of the fact that you're the principal investigator in this trial and ask a number of questions about the progress of the vaccine trial, of your vaccine trial, but also the prospects for a vaccine. And then the final area that I'm hoping to discuss is just what does the next few months hold in store for us. Today, I think it's September the 13th. Clearly, as we'll find out in the course of this discussion, we are seeing now a declining epidemic, or at least declining numbers. But will there be a second wave? Should we let down our guard? Those are the type of questions that we are going to entertain this evening. So Shabir, the last time you and I chatted, the 28th of June, we were in a very different place with this epidemic. We were anticipating, I think we were on the cusp of the first big surge. We were seeing increasing numbers of deaths in the Western Cape and then in Gauteng, and throughout July and into August, COVID-19 ravaged our country and ravaged our healthcare system in many respects. But now, as I said, it's September the 13th. I looked at a bunch of graphs this afternoon, and it's clear that we are on the other side of that wave. So I want to ask you, what happened between May and now, and how do you, as our one of our leading vaccinologists, understand? Were we right about this epidemic? Were we wrong about this epidemic? Tell me how you read the last few months.
So good evening, Mark, and good evening to the attendees. So Mark, I think the bottom line is no one could have predicted what has evolved in South Africa particularly. What we've experienced in South Africa has been really unusual when it comes to this epidemic, and South Africa in sub-Saharan Africa is one of few countries that has been reasonably able to understand what's happening with the outbreak, simply because of our ability to test compared to many of the other sub-Saharan Africans. But even our ability to test lags behind what, as an example, takes place in the United States and many high-income countries. Now, if you had told any of the modelers in May that roughly about 35 to 40% of South Africans would be infected, I don't think any of the modelers, in fact, modeled for that. The way the models were done is that the majority of models estimated that we would sort of peak at a time when about 25% of the population had been infected. And much of the numbers in terms of hospitalization, need for ICU beds, need for ventilators, number of people that would die from COVID-19 based on the models really was centered around that assumption. What we've seen in South Africa, at least based on early data from the Western Cape as well as Gauteng, is that in highly densely populated areas of the country, in Gauteng, as an example, in Soweto, in the inner city, in Hillbrow, in Tshwane, between 35 to 40% of people have been infected with this virus. And similarly, what they've reported in the Western Cape, between 35 to 40% of people have been infected with the virus. What that hasn't translated into, despite the reported number of COVID-19 deaths, which itself probably is an underestimate based on what the South African Medical Research Council sort of models as being the excess mortality for this time of the year, we haven't seen that translate to huge amount of deaths from COVID-19, huge amount of hospitalizations, overwhelming of our healthcare facilities. That simply didn't really transpire to the extent that most modelers predicted it would. So the big question is, why not? And right now, it's all speculation as to why did this not happen in South Africa, despite the high force of infection, especially in the urban metros. And we can go into different hypotheses. The one that I favor as an example is a possibility that there was some sort of underpinning immunity that was present in South Africans, possibly because of previous exposure to common cold coronaviruses. And we know that exposure to those common cold coronaviruses, based on studies that have recently been reported from Europe, from the United States, does induce some level of cross-protective immunity against SARS-CoV-2. That is one example, one possibility. The other possibility, some people would argue, is because of the younger age group demographic of South Africans. But to a large extent, that is sort of offset by the higher prevalence of tuberculosis, by the higher prevalence of diabetes, hypertension, obesity in South Africa compared to Northern Hemisphere countries. So I don't think age itself is the reason why we didn't see this huge number of...
We're struggling to hear you.
Disease and death from COVID-19. Now, another intriguing possibility is we obviously had lockdown. And able to hear me now, Mark? Hello?
You keep breaking up a little, Prof, but keep talking and let's see where we go.
So another possibility in terms of why we didn't experience the huge number of cases come in terms of the lockdown is that this sort of concept that when people wear masks, as an example, even though the mask might not be 100% protective against becoming infected, it might actually reduce the inoculum load. So the amount of virus that the person becomes infected with is lessened by people wearing masks. So like I said, there's a number of possible reasons, and we don't know which of those reasons contributed to us not experiencing massive number of cases of hospitalization, massive number of people dying from COVID-19, despite a huge force of infection that's taken place, especially in the urban metros. But I need to caution, that doesn't mean that we're completely out of the woods. When I say, and you might have seen it was reported over the weekend in one of the newspapers, that South Africa has reached herd immunity without us even realizing it. We've reached a threshold of population infection, which allows for herd immunity in the context of the use of non-pharmaceutical interventions, even if we're not completely adherent to these non-pharmaceutical interventions. Once these non-pharmaceutical interventions start falling away, people become more complacent about it, what would happen is that that percentage of infection that already has taken place would not be adequate for herd immunity. So there's sort of a balance that we need to strike in terms of how we move forward. It would be way premature to say go back to life as normal because we've reached herd immunity. We haven't reached herd immunity in terms of an open society. We've reached herd immunity possibly in some areas in South Africa, especially those areas where there was a high force of infection, but in the context of some level of utilization of non-pharmaceutical interventions.
Thank you very much, Prof. You've said a lot of important things in there, and I just want to rewind a little bit to just understand some of the things you've said. You started by saying, and I think many listeners will be surprised to hear this, that we had 35 to 40% of the population infected with this virus. I mean, that's 20 million people. I'm not great at maths, but that's a lot of people and a lot more than the official figures of 600,000. On what do you base that figure? Can you just answer that question to begin with? And then I want to ask a couple of questions about deaths as well.
Right, so we need to just recall that when we talk of 650,000 infections having been documented, those are infections that are documented by PCR testing. When we see who's being tested, Mark, can you hear me now?
Yes, that's a little bit better. Sorry, I'm sorry. Okay. I know you have computer problems. Okay? So just go back a little bit. So 35, 40%.
Yeah, so like I said, when we talk of the number of 650,000 people having been infected in South Africa, those are documented cases. And we need to sort of break it up. Firstly, when we're looking at those numbers, in terms of who has been tested, more than 50% of the individuals that have been tested as COVID positive are tests that have been done in the private sector. And we know that the private sector does not take care of 50% of our population. Secondly, what we've discussed before is between 40 to 60% of people that are infected with this virus would be completely asymptomatic. But those count as infections. When we test for antibody, and the number that I'm citing, 35 to 40%, is based on antibody testing that tells us who has been tested, who has been infected at least 3 weeks before. When we do so, 40 to 60% of people would have been asymptomatic. In addition to which, probably the majority of people, especially those making use of the public sector that were mildly symptomatic, simply didn't actually get tested. Now, in terms of other models, and there are models that are done by IHME, there's models that have been done by the London School of Tropical Medicine and Health, and these are models for South Africa as well, in terms of the number of people that have been infected. As an example, at the peak of the outbreak, when we were reporting 14,000 cases each day, the IHME model estimated there were 80,000 new cases each day in South Africa. The model from London School of Tropical Health and Medicine estimated there were 60,000 new cases each day when we were documenting 14,000 cases. So based on the seroepidemiology, coupled with what many of the other models have done, and the models basically adjust for under-testing essentially. It looks at who's being tested, it looks at the positivity rate of the test that's coming back, and it makes adjustments and gets to sort of a figure in terms of the number of people that are likely infected. And pulling all of that together, certainly the number of people that have been infected in South Africa is way above 650,000. I think we'll probably see the local modelers release data in the next week or so, and their numbers are going to be close to the numbers that you're sort of mentioning, in the region of 15 to 20 million.
Okay, so that's a lot of infections. Prof, a number of people are asking if you could, one, speak a little bit slower, and secondly, if we run into problems with the signal again, I'm going to ask you to switch off your video. 15,427 confirmed COVID-19 deaths, but the Medical Research Council records 42,000 excess deaths between the 6th of May and the 1st of September this year. Can you just explain again, slowly if you can, why is there this difference between the 15,000 and the 42,000, and what is this excess deaths that the MRC is telling us about? I can hear you, Prof.
Okay, so my apologies. I've taken it. I think the headsets might have been a problem.
So in terms of the excess mortality and the COVID-19, the sort of discrepancy between the two. So when we look at South Africa, and this is not unique to South Africa, as I mentioned before, even when it comes to the issue of the number of people that have been, in terms of the number of people that have been infected. And unfortunately, the same thing goes for people that have died from COVID. Not everyone that has died has basically been investigated for COVID. And in many instances, people or those deaths that have occurred have not been reported as COVID-19. And we also need to appreciate that many people possibly didn't even come to healthcare facilities and actually chose to be managed possibly at home. And those deaths might have actually occurred outside of healthcare facilities. So if you ask me what is the closest number, if we use the Western Cape as a benchmark in terms of the ratio of excess mortality to COVID-19 deaths, and we do the same sort of adjustment for all of the other provinces, right now where we're sitting possibly is that there's been roughly about 30,000 people that have died from COVID-19 in South Africa, rather than 15,000. And that is just using the Western Cape as a benchmark in terms of the difference between the excess mortality from natural causes and COVID-19 deaths.
Did you say 50,000, Prof? So that's your estimate.
30,000.
30,000. Okay, thanks. Thank you very much for that. I saw a report of some research done by Discovery Health suggesting that the lockdown has contributed to lessening the mortality, the number of deaths. They suggest that it will have prevented 16,000 deaths by the end of the year. Do you think that the lockdown helped us? Looking back on it, do you think that it was a good thing to do and that it gave us the time that we needed to learn how to treat people with COVID-19?
So Mark, in terms of 5 lockdown, to revisit into a lockdown. And at the start of the lockdown, the behind to save life in terms of better preparing our healthcare facilities. Where the lockdown worked, at least for some, is that it certainly brought us time in terms of facilities, really made use of that opportunity, or they didn't optimize the opportunity. As we saw to some extent in Gauteng, there was at least some preparation of number of beds that were available, as well as in terms of ensuring amount of PPE. So I think in terms of together it didn't work. Because even during the lockdown, what transpired during level 5 lockdown is that the effective reproductive rate, which if you have flattened the curve should be less than 1, was roughly 1.5. Contain community transmission, and if the level 5 community transmission, communities don't have had 35 to 40%.
Prof, I think Professor Mardi, I'm looking at Professor Mardi. I'm looking at the messages that are coming through, and what you're saying is really important, but it's breaking up all of the time. And I think that if listeners can be understanding and patient with us, Professor Mardi is going to go offline and reconnect, and hopefully when he comes back we will have a better sound, because this is an important discussion and it's very, very frustrating as it is at the moment. So I really apologize to the extent that we have any control, but I saw a couple of questions. So the official statistics on death as of today are 15,427, where it is confirmed COVID-19 deaths. But the Medical Research Council points to or not only points to, but documents, because the Medical Research Council counts death certificates, 42,396 deaths, above the average between the 6th of May and the 1st of September this year. And in their report, they say that a significant portion of the current excess mortality being observed in South Africa is likely to be attributable to COVID-19. So they attribute most of those excess deaths to COVID-19, although of course there will be deaths as a result of the fact that people have not had normal access to healthcare services during the period of the lockdown. Prof. Mahdi gave us a figure which he admits is an estimate of 30,000 COVID-19 related deaths over this period, and was trying to explain the reason why the death rate is still lower than was initially modeled. When Professor Mahdi comes back, if he comes back, I'm going to move on. Well, I'm going to ask him one last question, which is, are we through this first wave? But then I want to move on to the vaccine trial. If we continue with these technical difficulties, a number of you are suggesting that perhaps we just postpone this because the information is too important, and I will consult my bosses at the Daily Maverick as to whether that is in fact what we should do, because I think this is very, very important. I'm just trying to, if you'll allow me, just to check my messages to see what's happening with Professor Mahdi. I'm told he's coming back. I'm trying to think what else I can tell you as the host as we wait for Professor Mahdi. I mean, one of the questions that I was planning to ask him was what has been the impact on other health services, and what has been the impact on management of other major diseases in South Africa as a result of all of our focus on COVID-19. I, for example, have seen a report in the last few days, a very concerning report about an escalation of tuberculosis. Professor Mahdi is back.
Hi, Mark. Sorry about it.
Thank you. Good people who are listening in, apologies again for everything. I hope that Professor Mahdi will be clear to us now. If we fail again, then given that I'm not a professor of vaccinology, we may well have to postpone this and try again on another day, and I'll apologize. But Prof. Mahdi, you were explaining about mortality and death. I don't know if you finished about that. If you had, I wanted you to move on and just give us your view as to whether we have now passed the peak, whether the first wave of this COVID-19 is over.
Yeah, so Mark, I think all indications are that we're very much on the downward trajectory. And in the Western Cape, in Gauteng, we're pretty much on a downward trajectory as we are in many of the other provinces. And that's based on a number of metrics. First and foremost, as you're probably aware, the number of positive cases that are being reported on a daily basis for the past week has averaged around about under 2,000. And in fact, over the weekends, like under. That the more important metrics are that in terms of hospitalization, the rate of hospitalization, in addition to which, even when you look at the excess mortality, and the excess mortality lags by about 2 weeks in terms of the MRC reports. Already 2 weeks ago, as of the 1st of September, we've seen across almost the majority of provinces, in fact, all of the provinces, that the period has actually been on the decline. And as of the 1st of September, I think the excess mortality was only about 10% over and above what was predicted for that time of the year. And this is happening across all of the provinces. So we're certainly on the downward trajectory. A issue that we face now is what's going to happen if we become less adherent to non-pharmaceutical interventions. So like I mentioned earlier, even though we've reached herd immunity at a level that is adequate when we're using non-pharmaceutical interventions, once we become less adherent to the non-pharmaceutical intervention, increase in terms of transmission, and we will likely see a resurgence. But when we see that resurgence, in all likelihood, it is going to be less severe than what we experienced this time around, which itself was probably less severe than what was predicted by most people.
Okay, so that's an important point, which again, I think people need to understand, and I want you to unpack it a little bit, that you think that there will be, people call a second wave. The size of the second wave, if I understand you, will be very much dependent on how adherent people continue to be wearing masks, to hand washing, etc. But why do you think this second wave will be less severe? I mean, I was looking today at what's happening in England again, rapid escalation, hospitals on high alert, and increase in the number of hospitalizations. And what do you base your belief that perhaps it will be less severe the second time round?
Yeah, Mark, but I'll try to answer the question. I think I got most of it. So I think the United Kingdom, as well as France and Spain to some extent, they actually are examples in terms of how difficult it is to interpret the data at face value. So as an example, if you look at what's happening in France right now, in the midst of a second wave. In fact, this number of cases that are being documented this time around is almost exceeding the number of cases that were documented the first time around. But that has got more to do with differences in terms of testing strategy. So the first time around, they were particularly focused on individuals that were being hospitalized. This time around, they got a much lower threshold in terms of who is being investigated. So the numbers are the same, but the case fatality rate is completely different. So in the first wave, where they were focused on hospitalized cases, the case fatality risk was roughly about 12 to 14%. This time round, the case fatality risk is about 2%. But that is, like I said, they're using a different strategy in terms of who is being tested, how they're going about doing the test. There's many more younger individuals that are coming forward to be tested. So it's difficult to sort of make a comparison even within a country unless there's some sort of standardization in terms of the manner in which testing was taking place at the time of the first wave as well as at the time of the second wave. But what is being experienced in the Northern Hemisphere to some extent is predictable. And I think that to some extent it will also happen in South Africa, but hopefully to a lesser extent. So in Spain and in France, despite them having a really severe first wave, and we saw this huge number of cases of COVID-19 death, in a sort of ballpark of what we probably experienced, roughly about 30,000 COVID-19 deaths. What's happening there is that in that first wave, the percentage of the population that were actually infected was not that high in those countries. In different areas of the countries, it ranged from as low as 3% and sort of in the more affected countries, roughly about 12 to 15%. Unlike in South Africa, where the number of people that have been
I've lost you, Prof. I don't know if I'm alone in that. Whilst I wait for Prof to come back, there was a question about what we know about the ages of mortality. There's very useful information on the National Institute of Infectious Diseases website. But the highest mortality has been between the ages of 60 and 69, just to answer that question. Prof, are you back? No, Prof is not back. There was also a question about not all people with comorbidities necessarily succumbing to COVID-19. And I think the person who asked that question, that's a correct observation. And that has a great deal to do with the management and the severity of that comorbidity. I'm sorry, Shabir is now rejoining the room. I have no control over this, everybody, but it's a great disappointment because I think the information that Prof. Mahdi is giving us is very, very critical to understanding where we've come from and where we are going, and how South Africa compares to the experience in other parts of the world, particularly in the Northern Hemisphere. Shabir?
Mark, I'm back. Can you hear me now?
Yeah, you're back. I can hear you. I hope other people can.
Okay, my apologies. This has been a bit of a disaster. So, Mark, I actually missed most of the questions that you asked there. I think the first one was the age structure of mortality and differences in terms of age groups.
Yeah, and I answered that, Prof, and I suggested to people that they look at the NICD website, which gives a very good breakdown of deaths by age, by gender, and so on. Prof, there was another question, and I'm going to ask you this because I know it's on people's mind. What can you tell us about reinfection and immunity? What is the state of understanding on that issue now? If I've been infected with COVID-19, I've recovered, am I safe? Explain that.
Right. So, Mark, I think when it comes to reinfections, the reality of all respiratory viruses is that people do become reinfected when they're exposed to the virus. So there's nothing new about, or nothing unusual about getting reinfected. But we need to remember that the reason you would recover from the first infection is because of your immune system having mounted a response, which eventually is able to get rid of the virus. And that same immune response induces what we call memory responses. Now, one of the challenges with COVID-19, because of the short period of time that we've been able to observe, is that we don't know how long that immunity lasts. Our experience with the common cold coronaviruses is that immunity, and especially what we call T-cell immunity, lasts for at least 2 to 3 years. So what it comes down to is that reinfections would occur, but when reinfections occur, in all likelihood, the second episode of infection would actually be less severe than the first episode. In addition to which, when reinfected, you probably would be less infectious because your body is now able to mount an immune response much sooner and get rid of the virus much quicker. And the amount of virus that you're shedding will probably be less than what you shed the first time round. So reinfection does occur, and it is to be expected because it occurs with almost every other respiratory virus that circulates on an annual basis. But fortunately, the subsequent episodes would be less severe.
Okay, so I think everybody should have understand that being infected once doesn't guarantee that you won't be infected a second time. But what Professor Mahdi is saying is that a second infection is likely to be less severe for a combination of reasons. Is that correct, Prof, in layperson's language?
Correct, because your immune system is better able to mount an immune response and much faster than the first time round.
Okay, and that gives us a good way now to move into your greatest area of love and expertise, which is the development of a vaccine for COVID-19. Can you tell us where things are? And a week ago, we were all a little bit taken aback when we heard that the trial had been suspended because of one adverse event in a participant in England. What have you learned so far, and how is this vaccine trial going?
So, Mark, you might have heard it was announced on BBC yesterday, in fact, that the suspension in terms of further vaccination in this particular trial has been lifted, which means we can go ahead with continuing vaccination. And that decision was made by the Independent Data and Safety Monitoring Board after they had done an intensive interrogation of the medical event that occurred, which was unexplained and could possibly have been related to vaccination. The Data and Safety Monitoring Board now have concluded that it's unlikely that event was actually related to vaccination. So they've given a green light in terms of us continuing with vaccination in this particular study. In South Africa, we basically just waiting for a review of the DSMB recommendations by the Ethics Committee and SAPRA, and we hope that will happen in the next day or so, and that would enable us to restart a vaccination as well. So that's where we stand currently in terms of that particular event that was reported.
And how is the trial going? How many people have you enrolled onto the trial? Are you able to give us any indication yet as to when we might expect a result? I know certain presidents in other countries of the world have been hyping the notion that we might have a vaccine before early November. Are you optimistic? Have you any results to report yet?
Yeah, so what I can say with fair amount of certainty is that we will not get results by the 3rd of November. In terms of exactly, so in South Africa, currently we've enrolled just over 1,800 of the 2,000 volunteer participants that we're targeting. So we almost completed enrollment. We would have completed enrollment in the past week had we not postponed vaccination. Now, in terms of when the studies, including the study in the United Kingdom and the study in Brazil, when these studies would be able to actually do an analysis to determine whether the vaccine protects against COVID-19 or not, is largely dependent on when participants actually develop COVID-19. So for you to be able to address the question as to whether the vaccine protects against COVID-19, you need to have X number of individuals that actually develop COVID-19. In South Africa, as an example, we need to get at least about 42 of our participants develop COVID-19 before we would be able to do such an analysis. When we started the study, when there was a huge amount of virus that was circulating in the country, I estimated that we might well get to that point by November of this year. Fortunately for the country, unfortunately for the vaccine study, now it seems that we probably will only get to those sort of numbers sometime in the first quarter of next year, because there's very little virus circulating. The participants are unlikely to be developing COVID-19 unless there's another resurgence. So that sort of factors which are beyond our control influences when we would get a readout from these studies as to whether it protects against COVID-19 or not.
And does the trial internationally depend upon the results from South Africa and Brazil? Does a final decision on the efficacy and safety of that vaccine only get made when all the country results are in, or could something happen in Britain that leads them to make a decision to make this vaccine available?
Right. So there's two parts to it. So a positive finding from any of the studies, be it the UK, be it South Africa, be it Brazil, would basically lead to a situation where vaccination might be recommended under what we call emergency utilization authorization. So that is sort of allows for vaccine to be introduced before the vaccines are fully licensed by regulatory authorities. Because usually for a vaccine to be licensed by a regulatory authority, they're also wanting a fair amount of safety data. So you can have a situation that you actually start allowing for vaccine usage before it completes all of the hurdles related to regulatory approval. And that wouldn't be unique for COVID-19. A very similar sort of situation existed as an example for Ebola vaccine in the DRC or in West Africa when there was an Ebola outbreak. So you can get this emergency utilization authorization for vaccination, but ultimately the vaccine will be licensed based on safety and efficacy data, especially from phase 3 studies. And those phase 3 studies are currently underway in the United Kingdom, in Brazil, as well as in the United States. And some of the studies would be enrolling up to 30,000 participants, as an example, the one in the United States.
Thank you. We got a question, would being vaccinated give you less or more resistance against reinfection?
Well, the signs are that vaccination probably would give you the same sort of immunity as with natural infection. Many of the studies that have been done, when they looked at immune responses, it appears that immune responses that are being induced, at least by the vaccine that we're evaluating, the Chimp-Ed vaccine, the immune responses after 2 doses of the vaccine is not very dissimilar to the immune responses that are induced with natural infection. Okay. So we would hope that the vaccine works at least as well as after someone has developed natural infection in terms of its immune response that's induced, if not better, but at least as well.
Okay. And two more questions on vaccines which have been asked. You mentioned that, at the point when there was a high number of new infections in South Africa, it gave the prospect of an earlier result, and now with declining numbers, it pushes those dates back. That links to the discussion we had earlier on about the second wave. And there's a few questions from listeners about when do you anticipate that a second wave, a second resurgence might take place in South Africa? Are we talking about a second wave later this year? Or are we talking about a second wave in 2021? What's your thinking there?
Right, so it's really difficult to predict. And in South Africa, to a large extent, it depends on how complacent people become about non-pharmaceutical interventions, how complacent people come about mass gatherings, as an example. So if we were to become more complacent and start not using non-pharmaceutical interventions, not using face masks in public spaces, start engaging in mass gatherings, then we would expect a resurgence sooner than later. I think based on the experience of the Northern Hemisphere countries, many of those countries are experiencing a resurgence after the summer vacation period. And obviously that's the period of time when people are going to be a bit more complacent about non-pharmaceutical interventions. So it might well be that we would start seeing less adherence to non-pharmaceutical interventions, that we might see people engaging in family gatherings, etc., during the December vacation period. And then come end of January, beginning of February or so, we might start seeing this resurgence. But like I said, it's impossible to predict because to a large, it's very sensitive to the behavior of citizens, especially in terms of adherence to non-pharmaceutical interventions and everything else that goes with it.
Okay, so you are of the view, and this is your message to listeners tonight, that wearing a mask, washing your hands, social distancing is as important now as it has ever been, despite the fact that infections are declining.
Oh, without question, because if we become lax about that, we will get a resurgence sooner than later.
And I think people are becoming lax about it from what I observe on the streets. Prof, it links to another question because, okay, so if people stop wearing masks, if people start gathering in large groups, the second wave will come sooner than later. A few people have been asking, should we be reopening our borders? I mean, we're now only a few months away from Christmas, believe it or not. Normally in December, lots of people in South Africa move to other parts of the country, but also lots of people come into South Africa from foreign countries, from Europe, from the United States, to holiday in Cape Town, and it's vital to our tourism industry. Do you think we should be opening our borders given the resurgence of infections in those countries, or should we be staying shut?
No, I think there's very little reason for the borders to be shut. In fact, opening the borders is probably will only have a nominal effect in terms of the future trajectory of this outbreak for a number of reasons. So we're not the countries such as New Zealand or Australia or Iceland, as an example, which are island nations that have truly been able to contain spread of the virus. We've got virus that is disseminated in terms of its transmission, and having a few visitors come across, even if they're infected with the virus, it's not going to lend to massive outbreaks. That wouldn't be the reason why we'd get huge outbreaks moving forward. And especially if those visitors sort of adhere to the same sort of non-pharmaceutical interventions, practices that we're recommending for South Africans. So there's very little reason for us not to be opening or allowing people into the country. As to people going out of the country, in fact, unfortunately for South Africans, there's very few countries that seem to be allowing South Africans into their countries. The United Kingdom, United States, and China, I think, are countries that do allow South African visitors. But many other countries at this point in time, from what I heard, have got restrictions in place in terms of South Africans traveling to those countries. But that might well change over the next few weeks when there's further decline in terms of number of cases that are infected in South Africa.
Okay, that's a very interesting. And you and being a member of the Ministerial Advisory Committee, that's the advice that you would give to government. No harm in opening up to international travel again.
Yeah, I think that would be the advice that I would give, and I would suspect that many of the other members would provide similar sort of advice, because, like I said, we're certainly not in the sort of space of trying to contain viral transmission in South Africa, which is really when you need border closures.
Okay, so again, just to summarize, yes, opening borders would mean we import cases from all over the world, but the number of cases that we import would be relatively small compared to the still significant number of infections taking place through local transmission in South Africa. That's basically what you're saying, and so it would serve no benefit.
Correct.
And a linked question to that, Prof, because my mother lives in the United States. She can't visit my sister in England because she has to spend 2 weeks in quarantine if she went to England. Would you suggest that we quarantine international visitors if we reopened our borders?
Certainly not. If we're not doing quarantine of close contacts and we're not doing it in any measurable scale in South Africa of South Africans, there's almost no reason to be putting incoming visitors into quarantine. So again, it depends on what your strategy is and what you're trying to achieve. If we were really wanting to go to a scenario where we're able to contain the spread of the virus, which we're beyond that period, we're beyond that phase, then you can go about trying to go do close contact tracing and putting people into quarantine. But that's not where we are in terms of the epidemic. So there's very little reason, again, to be placing people that are coming into South Africa into quarantine for 10 or 14 days. In fact, it's happening at the expense of taxpayers. And I think that's actually a waste of money to be putting people into quarantine in the hotels at the expense of government.
Thank you. Important advice. One last question that I just saw on this before we move on a little bit again is, so if you support opening borders, would you support opening stadiums and churches? I mean, the other thing that happens at Christmas is lots of people go to church. Would you support people congregating in their hundreds in churches and stadiums again?
Yeah, so Mark, unfortunately not. I certainly wouldn't be supportive of any sort of mass gathering. And that's what I was trying to emphasize earlier. Mass gatherings are exactly the type of thing that's going to allow for super spreader events, and it's going to allow for rapid transmission of those individuals that are still susceptible, and we're going to see a much quicker resurgence, which is what we're wanting to avoid. And when we get that resurgence, if you allow for this sort of mass gatherings, you're going to get many infections over a short period of time. So I don't mind infections being drawn out, which is pretty much what we sort of achieved the first time around with the different levels of lockdown. What we're trying to avoid is many infections taking place over a short period of time, and that is exactly what mass gatherings lends itself to.
Thank you. So again, but stick with the basics is your advice. Correct. Just this last question, Sarah G asked a good question on international travel, and it was in my mind as well. Is there not a danger of importing other strains of COVID-19 into South Africa via international travel?
Right. So, Mark, all of the data currently does not support that there's been any significant mutations with the SARS-CoV-2 virus, and particularly that there's been mutations that has resulted in strains that are more infectious. There's one experiment that's been done in a lab which suggests that one of the strains, which in fact was sort of an early mutation that occurred, that has been reported, might be more infectious in the lab. But in terms of epidemiological data, there's no evidence to suggest that the few mutations that might have occurred up to now actually results in virus that's more infectious. So the type of virus that's going to be imported, even if there might be some mutations, it's unlikely to have any sort of meaningful impact in terms of infectiousness, in terms of the transmission.
Thank you. So, again, a fairly decisive answer. Prof, we're coming to the end of our discussion. We've only got 6 or 7 minutes. It's been complicated and challenging, but I think that you've given us a lot of very, very valuable, important and new information about where we are with COVID-19. I want to go back to vaccines. So you're fairly optimistic, I think, we will develop a COVID-19 vaccine. I've heard you say that, and other virologists say that part of the reason you've just said it is that this virus is fairly stable, it doesn't mutate frequently. We will have a vaccine at some point. 2 questions. There may be a vaccine, but will we have access to it in South Africa? Are you confident? Have our government started pre-ordering millions of vaccines in the way that the UK and other countries have done? Will we get access to it? And if we do get access to it, will it make a big difference?
Right. So, Mark, in terms of access, we're not in a position of the UK or the United States to be able to put up billions of dollars to pre-order vaccine that we're not even sure whether those vaccines are going to work. The best opportunity for South Africa to be able to get early access to vaccine is to sign up to the COVAX initiative, the COVAX facility, which is sort of an initiative that is being managed by Gavi, WHO, and CEPI. And that basically sort of engages with companies to be able to procure hundreds of millions of doses of vaccine. And then it sort of provides a channel through which governments, including middle-income countries, can access vaccine at a reasonable price for at least some percentage of the population. So we're not talking of vaccinating 10 or 20 million South Africans over a short period of time. Even if the COVAX facility works, and we're not too sure how successful it's going to be, the best case scenario for South Africa by June of next year, as an example, if vaccines are shown to work this year, is that we might have sufficient number of doses for about 5 million individuals, which equates to about 10 million doses. But government needs to show political and financial commitment to the COVAX facility at this point in time for it to be in a favorable position to gain access to vaccine, at least for a certain segment of our population.
Thank you. And do you think it's showing sufficient commitment to the COVAX initiative?
I think government has raised its hands and it is buying it into the contract. I think into that concept, but obviously that's a question that's better directed to National Department of Health, because the COVAX facility, in terms of governments needing to show financial as well commitment, I think that deadline passed on the 31st of August. So hopefully government has taken up that offer to be part of that initiative.
Great. And then the last question on this, Prof. So let's go forward 9 months. We're in May or June 2021. Because of your heroic efforts and others, we have a vaccine that has a reasonable efficacy. Is that the end of the COVID-19 story?
Oh, no, certainly not. I mean, the best case scenario with COVID-19 is that it becomes a seasonal virus, or it becomes a virus that sort of causes some sort of outbreak, perhaps every 2 or 3 years, if not annually. That would be a best case scenario. So I think what we're facing is not any eradication or elimination of this virus. That's extremely unlikely to occur given just how widespread this virus is, and also given our experience with other common cold coronaviruses, some of which have been circulating in humans since the 1960s. So unfortunately, there are going to be segments of our population that will still remain vulnerable to developing severe disease and to dying from COVID-19, even after a vaccine has become available. And for some parts of the population, we don't know how long immunity will last with these vaccines. And it might be they need to be revaccinated every 2 or 3 years, or even annually. So we're still a far way off. We shouldn't even imagine or think about the elimination of this virus, because I don't think that features on any of the scientists' radar right now.
So again, no magic bullet. Very important as part of our armory of controlling epidemics, but not a magic bullet and not a reason to stop taking personal precautions. Prof, we're almost out of time. Lots of people are thanking you for your insights and leadership on science and on this issue. I want to finish with one question before we sum up, and it takes us back to this question of the lockdown. Are you worried that one of the kind of unintended consequences of the lockdown has been a negative impact on our control of other diseases? Previously, you'd mentioned worries about immunization, etc. I was saying whilst you disappeared for a few minutes that we'll probably have 65,000 TB deaths this year, and that TB testing has declined significantly. Do you still have those worries, or do you think that we're going to put things back together again pretty quickly?
Yeah, Mark, it somewhat speaks also to the issue of excess natural mortality, and a difference between the 42,000 and what they estimate to be the 30,000 COVID deaths. Those 12,000 excess deaths are due to non-COVID issues related to our reaction to COVID-19. As you mentioned, the deaths that might occur because of diminished management of HIV and TB, those are not deaths that are going to occur immediately. Those are deaths that will probably roll over into next year or into the following year, because people have been delayed in terms of initiation of treatment for tuberculosis. People have, the antiretroviral treatment has been interrupted. That lends itself to resistance when it comes to antiretrovirals. And all of those are going to have sort of medium-term consequences. In terms of vaccination, there was a 25% decline in terms of immunization of children in South Africa during the level 5 lockdown. So we're going to need to figure out exactly how to reverse those sort of negative consequences of our reaction to COVID-19. I'm not saying our reaction to COVID-19 was not necessary, but it comes with some cost. And it's not just South Africa that's been affected. Many other sub-Saharan African countries are going to be affected with exactly the same sort of problem. And this is something that we urgently need to start figuring out in terms of how to sort of reverse those negative consequences over the next few months.
Thank you, and that is something that we will have to come back to. So, Prof and the listeners, thank you so much for your patience. Prof, thanks for persevering. I've been a lot more stable than the first half. I'm not going to sum up everything that you've said, but I think a different perspective and understanding of COVID-19 than they did an hour ago. The idea that there's 35 to 40% population infection, 30,000 deaths, that there will be a second wave. Its size will depend upon how people conduct themselves over the next few months. Interesting points you've made about supporting opening of international borders, but there's no purpose in quarantining. There's been a lot. I think we've managed to get through a lot. There will be a report tomorrow morning in the Daily Maverick, a write-up of this webinar, as well as a recording of this evening. And I hope that we will have another chance to bring you further updates because COVID-19 is still time. So, Professor Madhi, do you have anything you would like to say before I close this evening?
Thanks, Mark, for the opportunity, and my apologies for the IT problems on my end. Hopefully it won't repeat itself in
Silence. Okay, I spoke too soon. We've lost Professor Madhi. Thank you all. Thank you to the people who helped put the Maverick Insider team for putting this together. Stay safe, stay well, continue to use masks and wash your hands and take this epidemic seriously. Thank you all very, very much. Thank you. Bye-bye.